check that. If any of you see the quiz questions come in, it would be helpful to me if you let me know that they made it. Um, and with that, let's just go ahead and get into this. Okay, so first, what is nuclear medicine? This is a question that's a little more complicated than you may suspect. And then we'll talk about some selected nuclear medicine exams that I think are important for people to understand that are not going into radiology, and things that might help you when you're interns, and just general nuclear medicine study and knowledge that I think would benefit any physician. And then I'll also talk about some nuclear medicine therapies, because nuclear medicine doctors are mostly diagnosticians, but they are also treating physicians. Um, okay, just reading some of these other comments. Okay, so what is nuclear medicine? And sorry, I need to arrange my screen a little differently here. Yeah, I'm struggling for real estate on my display because I'm using a laptop, but here we go. Okay. So nuclear medicine is actually its own specialty, and it is also part of radiology. So that's a little bit confusing. But historically, and even today, you can find nuclear medicine programs that are completely separate from radiology. So it is its own field. It has its own medical board, the American Board of Nuclear Medicine. And if you choose, you can still go through the pure nuclear medicine route. However, when nuclear medicine started merging with radiology, and that mostly happened when we started having PET CT, because initially it was only PET, there is no CT. And then we realized we can fuse the PET images on a CT image, and now you have a PET CT, and that goes along with all of the information that you can see on a CT scan. And at that point, radiology started getting more involved. And we're at the point now where within the last few years, there's been discussion on whether the American Board of Radiology should just completely incorporate nuclear radiology. I don't want to say take over, but that's the way it appears to be to nuclear medicine doctors, is that this could be seen as a takeover of nuclear medicine by radiology. There was a vote by the ABNM to see if they would dissolve and just fall under the umbrella of the American Board of Radiology, and they opted not to do that. So as it stands, we still have two separate medical boards, and to be a practicing nuclear medicine doctor, you can go through either pathway. Um, I foresee in the future that more of the nuclear medicine practitioners in the country will be radiologists, because just by sheer number, there's way more nuclear. Um, so the term that is often used as nuclear radiologist versus nuclear medicine, but even then it's interchangeable. But there are just a lot more radiologists out there, and the training programs for radiology are a lot bigger. So by sheer numbers, there will be many more radiologists that are doing all the nuclear medicine, but not all of them. And there are certain programs, Stanford is one, WashU in St. Louis is another, where a lot of the practicing nuclear medicine doctors and um, attending physicians are not radiologists. They are pure nuclear medicine, and they do a good job. But just to be aware that there are two separate things here, and what I'm really trying to do is have 2 hours to present an overview of an entire specialty area in medicine. So it's a tall order. Um, when radiologists do nuclear medicine, most of them will not do any training beyond residency, but there are nuclear medicine fellowship pathways that you can do after a radiology residency. And there are also programs where you do a combined radiology nuclear medicine residency. And that's what I did. And I think that was a great option to be able to go through residency and also get subspecialty certification in nuclear medicine. So essentially, during my 4 years of radiology, I spent 16 months on nuclear medicine and the rest on radiology. But if I wanted to, I could also do a fellowship after. But I think that combined pathway can make a lot of sense. And then after radiology residency, I did a women's imaging fellowship as well. But that was my path. So what makes nuclear medicine different than radiology, and why did these start out in different places in the first place? Well, one easy way to think about this is that in radiology, you have external radiation, like an X-ray, that passes through the body, and then you form an image from that. Okay, so there's some sort of external radiation or some sort of external energy. With ultrasound as external sound waves that you pass through the body, and then you make an image. With MRI, it's the external magnetic fields and radio frequency pulses that pass through. With nuclear medicine, the radiation is internalized, and then you create an image after it's been internalized. So how do you get the radiation inside? Most commonly, it's through an IV injection. So you'll take a radioactive substance, send it in through an IV, or you can eat it. We definitely do that. Things like gastric emptying studies, you eat a radioactive meal, and then we watch it pass through the GI tract. You can do subcutaneous injections. We do that for sentinel lymph node studies, where you inject sulfur colloid in these subcutaneous tissues and then see it move in the lymphatics. We do intrathecal injections to evaluate for things like normal pressure hydrocephalus. That's less common now, but it's something you can do. You can also inject CSF shunts, like intracranial shunts, to see if they're patent. So you inject the reservoir up in the skull, and then you watch the radiation travel down into the spinal cord CSF. And you can inject intraperitoneal, and there's something called hepatic hydrothorax, where you end up with a pleural effusion, but the cause is actually from abdominal ascites that moves through the diaphragm up into the chest. But sometimes you can wonder, is that actually what's causing the pleural effusion, or is there something else going on? So a nuclear medicine doctor or a radiologist could perform a peritonesis or paracentesis, essentially get a catheter in the peritoneal cavity, inject radiation into the ascites, and then you sit there and watch to see if it crosses the diaphragm into the chest. So those are a few examples of how a nuclear medicine study could be performed and the types of things that we do. If you have any questions along the way, feel free to send me a comment or go ahead and ask. So I want to spend a few minutes, because you're in this radiology group and a lot of you are going to feel this way and have these opinions, and my hope is to broaden your mind a little bit. So 3 common myths, and this applies to nukes, but also radiology. 1, radiologists don't see or treat patients. 2, radiology is only about anatomy. 3, I will fall asleep if I sit in a dark room all day. Can't tell you how many times I've heard that as a radiologist. So let's talk about each one just briefly. So to get into that, what is this? Now, whether you've read the chapter or not, you still wouldn't know what this is. But is there any guess from you? What could this be? What am I showing you? Thyroid. Awesome. Let me get the comments here. Thyroid uptake. So we have a smart group here. That is a thyroid. Now, this is a nuclear medicine scan. So a few things. The thyroid. So what does this image tell us in terms of anatomy? Does it tell us anything in terms of physiology? I see someone said thyroid uptake, diffuse uptake. So uptake, we're now getting beyond anatomy and we're talking about physiology. Someone says symmetric, correct? No large mass, agree. So a few other things from this image. This is a simple image, but we can tell something about anatomy. We could tell something about physiology, the endocrine functioning of the thyroid. Um, can we use this imaging agent for treatment? We'll talk about that. Someone says yes. Does this image give me the opportunity to see the patient? Yeah, will I actually end up performing a physical and history on a patient because of this as a radiologist, keep in mind, who's not an IR? And will I be a treating physician? Okay, so what does this tell us in terms of anatomy? Well, you can take my word for it, but this thyroid looks a little big. You can see a connection between the two thyroid lobes, which is the thyroid isthmus. You do not see any nodules, and sometimes a nodule will actually show up as a white spot, meaning there's no activity. So thyroid cancer is unlikely. We have an enlarged thyroid. I see the isthmus, so I'm thinking Graves' disease. Okay, so this one image, we've gone to no cancer. We've gone to this is probably Graves' disease, and there's something else we can do as well. And that is this. So you guys mentioned some uptake, and that's true. You can get an uptake. Commonly, we look at 4 and 24 hours, and we know what normal values are. And in this case, this is elevated. So what we can tell you is that we injected radioactive iodine. The thyroid took up more of that iodine than is normal. So the thyroid is very hungry for iodine. So either it has lost its feedback mechanism to stop it taking up iodine, or something else is going on. But this is all consistent with Graves' disease. We have confirmed what the physiology is. We've also confirmed that there's no cancer present. And, sorry, can we use this imaging agent for treatment? Yes, it depends, but yes. So there's different types of iodine we can give a patient. In this case, it's iodine 131. Iodine 131 allows us to get an image like this. It also emits beta particles. And part of nuclear medicine is understanding a little bit about radiation physics, which I don't expect you guys to be experts on. But there's different particles that things can kick off, and beta particles are like little tiny cannonballs that are energetic, and they destroy the cells in the immediate surrounding area. This is really convenient for us because if you have Graves' disease, one of the best ways to go about treating it, and there are medications that patients can try, and sometimes it works and sometimes they don't. Sometimes people don't even want to mess with the medications because some of them have some side effects that you don't want to necessarily have to deal with. But you need to get the thyroid tissue out. So one option is to have a surgeon go in and remove it. You have, an incision on your neck. You have a recovery time. You go under general anesthesia. Another option is to swallow a pill of radioactive iodine. And within a week or so, thyroid is gone. Okay, that's pretty cool. In terms of recovery and symptoms, there's almost nothing that the patient has to recover from. You might have mild tenderness in the throat. You do have to avoid being around other people because your urine and saliva are radioactive, and you don't want them to ablate their thyroids if they won't benefit from it. So there are some things like that, but in terms of sparing a major surgery, that's a great deal. I would take a pill any day, and this is a one-time pill most often. One iodine pill, your thyroid is gone because those beta particles are present, and specifically because the thyroid is one of the only organs in the body that takes up iodine avidly. So you have a selective ablation of the thyroid tissue. That is helpful for Graves' disease. So iodine 131 can treat Graves' disease. Can it also treat cancer? And the answer is in many cases, yes. And even metastatic thyroid cancer, if the metastatic thyroid cancer cells take up iodine, you can treat them with radioactive iodine and not have to have chemotherapy. And the side effects from the radioactive iodine are so much less than chemo. Okay, it's a lot better than radiation. And if it's a low-grade cancer, it can really kind of clean up iodine anywhere in the body. So what I'm telling you is we have a great therapy here. This is the type of stuff that the oncology community is really striving to have for every type of cancer. A very cheap, easy, inexpensive, non-toxic, one-time treatment for cancer that selectively only goes to the cancer cells. I mean, that sounds too good to be true. Radioactive iodine has allowed us to do that for thyroid cancer for decades. Okay. Um, that's one example of what we do in nuclear medicine. That's one example of how what we do might be a little different than what the common perception is of a radiologist. Okay, this is not just sitting in the dark room. It's not just reading scans. It's actually interacting and treating patients, using images to guide therapy, using targeted therapies to treat cancers. And it's a very powerful way to go about things for the right condition. Okay. So, will I perform a history and physical? Yes. Um, let's see, I have a question.
Yeah, I had a question. So my understanding is when we do radioactive uptake studies, cancers of the thyroid are cold nodules because they don't take up as much iodine. So excuse me. So how is it that iodine gets to the thyroid cancer if cancer doesn't take up as much iodine? Does that make sense?
Yeah, it does, and there are ways we can test for that. But so typically the cancer doesn't take up iodine as much as the normal thyroid tissue. That's not always the case, but it still takes up enough of it. Okay, so not as iodine hungry as normal thyroid, but it still definitely is hungry. And you also do things before you treat to really make those cells want iodine. So you go on iodine deprivation, and you can also give artificial TSH to really stimulate those cells. And so you basically put the body in as hungry of an iodine state as possible for those thyroid cells, and then you give the iodine, and then they take it up. But yeah, that's something we're going to talk about on here is what happens when cells stop taking up the iodine. So that's a good question. Cold nodules are more concerning for thyroid cancer. That's true because it tells you that there's something in the thyroid that's not behaving like normal thyroid tissue should. Okay, because happy thyroid tissue takes up iodine. Then I have a question. How common is worsening of um, ophthalmopathy? That's a tongue twister that I obviously can't say well right now. Um, it can happen. I've never seen it happen. But if someone comes in with really bad proptosis, you have to be concerned about that possibility. You might pre-treat with steroids. If it was really severe, um, you might not opt for iodine first. You might want to go on some medication first and see if you can get it to back down. It is known to happen, but it's not common. Okay. All right. So sounds like you're all pretty familiar with some of this stuff, which is great. In terms of if you have a patient or a family member who ends up needing radioactive iodine, and that may happen because thyroid cancer is not all that uncommon, um, be aware that they will have to isolate strictly from kids, especially, and other family members. Have precautions so as not to get that radioactive iodine spread around. We're all very familiar with self-isolation right now. But you would have to do things with that, like not share a bathroom with anyone, not use any public restrooms. And if somebody is breastfeeding, they cannot breastfeed because you do not want to ablate a baby's thyroid, right? That's really bad. Okay. So radiologists don't see or treat patients. That's incorrect. So obviously everybody knows about interventional radiologists seeing patients. People less commonly think of nuclear radiologists seeing patients, but they do. And also, I'm a breast imager as well, and I see patients very frequently on breast imaging to tell them what the results of their imaging exam is, to perform biopsies, that type of thing. Most radiologists end up in private practice, and almost all of them will perform procedures as well. There are a lot of procedures that are performed outside of interventional radiology. Not that they don't know how to do this, they are experts at these, but pretty much every radiologist is trained to perform biopsies, thoracentesis, paracentesis, lumbar puncture, joint injection, feeding tube placement, if you're a pediatric radiologist, intussusception reduction, and this is only a list of what's out there, but radiologists are also proceduralists in a lot of ways. And even to perform some exams, you have to interact with patients. Ultrasound, unless your patient can't talk, which would be very uncommon with an ultrasound, you are interacting with them. With fluoroscopy, you have to be there in person with them, tell them what to do, talk to them afterwards about what you see. And also radiologists treat and manage contrast reactions. So that's a list of ways that we do see and ways that we do treat patients, even if you're not in IR. So you can cross that one off. I'm not saying that you go in and run a clinic. No, that's not true. But do you see patients on a regular basis? Absolutely. Okay, radiology is only about anatomy. That's not true either. Really, for nuclear medicine, it's the physiology almost as much as the anatomy that allows you to make a diagnosis. You have to understand the physiology of the tissue of interest. We'll talk more about that, and I think that'll make more sense after I'm done with this presentation. Even outside of nuclear medicine, you have things like MRI with multi-phase CT. That's in multi-phase MRI. That's really getting at physiology. You're looking at neoangiogenesis, fibrosis, things like that. Radiology also requires procedural skills, which isn't just anatomy. And I'm not going to talk the whole time about this, I promise. I will fall asleep in a dark room. You know, that might be true. If you guys sat in a dark room with us all day, you might. Sorry, I'm going to cut back. How long do patients need to self-isolate for iodine? It's usually really strict isolation for 3 days and maybe up to a week to avoid being around kids. Okay, but 3 days is generally pretty good. And there is some variation. They're working to make national standards for this, but right now it's a little bit up to each institution, but 3 days is a good rule of thumb for self-isolation for iodine. So back to falling asleep, just know it's boring to watch other people practice radiology. Is very different when you're actually doing it yourself. It's very mentally engaging. Okay. And honestly, it's one of the areas I've found in medicine out of everything I rotated through as a student and intern, where you just spend more time thinking than anything else. I love that about radiology. It's just a mental challenge, and you know, you're not charting, you're not doing things like that. You're sitting there almost all of your time just trying to figure out what's going on. So I find that very rewarding. Now, overnight call, you might fall asleep in the reading room. I've certainly fell asleep in a reading room, and radiology has a lot of overnight call. So expect that if you go into it. Okay, enough with that. Let's talk about what a radiopharmaceutical is. I believe this is in the chapter of your textbook, and it's kind of an important thing to understand with nuclear medicine. So radiopharmaceutical is a combination of a radioisotope, and that's something like, it's an isotope, so iodine, technetium, gallium, there's many of these. And you take those radioactive isotopes and you attach it to a pharmaceutical. And as you know from physiology and pharmacology, pharmaceuticals deal with the physiology of the body in some way. That pharmaceutical substance is targeted to a specific tissue to treat a specific process in the body. And so what you do is you take a radioisotope and put a pharmaceutical tag on it, and that pharmaceutical will determine where the radioactivity ends up being, okay? So for example, if you want to do a bone scan, which we'll talk about, you attach technetium to something called MDP, and MDP looks a lot like phosphate. And so when you inject that, that phosphate will form kind of like calcium phosphate, and it goes to bone and calcium, okay? For a HIDA scan, which tells you about cholecystitis and liver function, that type of thing, you attach it, again, technetium, to something that is HIDA, or there's IDA, there's mebufotenin, there's different things. but basically they're all substances that get conjugated and go through the biliary clearance system. And that allows you to look at bile transport. Okay, so those are two examples. The radioisotope that we most commonly use is technetium. I'll talk a little bit about why. But the various combination of the radioisotope and the pharmaceutical determines where it goes and allows you to image different physiologic or anatomic processes. Now, iodine is an exception because it is a radioisotope, but because the thyroid likes iodine, you don't have to put a pharmaceutical on it. How do we image these, or how do we use them? Well, most commonly after a radioisotope is injected, a radiopharmaceutical, you use a gamma camera, or you can use a PET CT camera, or for certain things you can actually not image and you can assay radiation levels in the blood or urine. There's ways you can estimate GFR, that type of thing. You can assay nasal secretions after you do an LP and inject indium to see if there's a CSF leak. Okay, there's different ways that you can use these to our advantage. This is what a gamma camera looks like on the left and a SPECT CT on the right. A gamma camera is this. This is a single head gamma camera in this case. Most of them nowadays are dual heads, so you'd have one here and one here. But there's crystals in here that detect the radiation that comes out of the body. And when you take these and attach them to a CT scanner, which is what this circle is back here, you now have a SPECT CT. SPECT without CT, SPECT is when you take the gamma cameras and you rotate them around the body just like you do on a CT detector. And that allows you to get kind of like a 3D nuclear medicine only image. So that's SPECT. CT, this is just like CT from radiology. Oh, great. The questions are there now. Awesome. So you can look at those. I think the only one I've covered so far would be something about iodine 131. Okay, so I don't think you're going to have any problems with that one. Okay, SPECT CT camera. So SPECT is from the nuclear medicine image, CT is there, and then you merge them, you have a SPECT CT. This is a PET CT. So a PET camera is different from a gamma camera. A gamma camera is really tuned to detect things like technetium. A PET camera is tuned to detect positron emitters. And the most common one of those is FDG, which is basically like radioactive glucose. And I'll talk briefly about that. Nowadays, we can also have PET with MRI. Whether PET MRI is really going to take over, I'm extremely skeptical. It's really expensive, and so far there have been almost no studies that show it does any better than PET CT. The PET MRI does allow you to avoid the radiation from the CT, but on the other hand, the radiation from a CT scan is continually getting cut, and it will continue to be lowered. And that as it continues to get lowered, that's less of an advantage to justify buying a $10 million scanner, okay? Because PET MRIs are really expensive, they're really cumbersome. But maybe. I think it's kind of cool, but it's a big question mark right now if it's really going to be worth its cost. Then there are other specialty cameras. You can get a molecular breast imaging exam. I'm not going to go in depth to this, but it's a specific camera designed specifically to evaluate the breasts for nuclear medicine. And there are dedicated cardiac cameras that are specifically only built for cardiac imaging. One advantage of these specialty cameras is that it allows you to image at a lot lower dose than if you try to do a cardiac scan on just a normal gamma camera. And often the images are higher resolution. Okay, so there's several of these. How do they work? I mean, we could talk, a whole day on this, but the basic that I think you should understand is that the cameras typically have used crystals and they scintillate. And scintillation means it gives off a flash or sparkle of light. And here's an example of these crystals. And when radiation hits these, they give off light. And so basically you put patients in a ring of these crystals, and then you see which crystals are scintillating. And from that, you create an image. The newest cameras no longer use these scintillation crystals, but they have direct detectors that are digital. and those work really well. They're very efficient, which allows you to lower the doses, but they're also really expensive. But in time, they will become less expensive, and maybe eventually everything we have will be a digital camera, which would be a good thing for patients because that can allow you to cut the dose and it allows you to image faster. So all of that is good. You just have to be able to afford these cameras, which right now some of them are really expensive. Common radioisotopes. There's a lot of them. I divide these by general nuclear medicine. And when I say general nuclear medicine, that is basically everything that's not PET, okay? And that's a common division, how we think of what we do. We have general nuclear medicine, and then we have PET. And the combination of those is pretty much what we do in a day. We read our general scans, we read our PET scans. Conceptually, they're very different, and they have different cameras. A lot of these are kind of byproducts of nuclear reactors, like iodine. In southern Utah, after all the nuclear testing, a lot of the cancer that happened was due to the radioactive iodine 131 that fell down from the sky to the people in southern Utah and Nevada. We still get iodine from nuclear waste, if you want to think of it that way, but it's a byproduct of a nuclear reactor. Technetium comes from molybdenum, which is also kind of nuclear reactor based. Other things like gallium, indium, and thallium are made from a cyclotron, and that is different from a nuclear reactor. A cyclotron is where you bombard elements to create other elements. And Huntsman Cancer Institute does have a cyclotron. They bought this very early, and it's been a great thing for our institution that we have our own cyclotron. Not every academic center has a cyclotron, so it's great that we do. A lot of them do, not all of them. We have the only cyclotron in the Mountain West region. And if you don't have a cyclotron, then the country has a network of radio pharmacies set up, and you can order these from the radio pharmacy, which will have a cyclotron and then a distribution network set up to get these to small clinics or wherever you might need them. Are most nuclear medicine agents carcinogenic? Also, are gamma rays carcinogenic? So, yes, these are all forms of ionizing radiation, and it is that ionizing radiation that can cause cancer because they go in and create free radicals and damage DNA. So, they all are carcinogenic, just like an X ray. I think I have a slide in here talking about what the difference is between a gamma ray and an X ray, but they're almost essentially the same thing. Okay, so nuclear medicine is a lot like X-rays. PET agents, also potentially carcinogenic. Now, when you really get into this, we don't know how carcinogenic. There's estimates that are probably imprecise. A lot of people feel like there's a threshold below which radiation does not cause cancer. And a lot of the studies we do could be in that threshold, but it's not proven. And until we know that they're perfectly safe, we'll always be cautious about it. Another question, what's that big thing they're building behind Huntsman? So it is a cyclotron, but it's for proton therapy. So that is for radiation oncologists. That will not be used by us in nuclear medicine. It's a radiation oncology tool. And the one thing I would know about that for you guys is that with proton therapy, the whole idea is that instead of treating cancers with X-rays, you will treat them with protons. And the advantage of treating cancer with a proton instead of an X-ray is that they are able to determine exactly what depth the proton will stop in the body. So for example, if you have a cancer that's right by somebody's heart, if you treat them with X-rays, you can angle and do what you can, but the heart will get some of the X-rays and the heart will have some radiation and potentially some damage from that. If you use protons, my understanding is they can stop it down to pretty much the millimeter level. So you could treat the cancer and spare the heart from any radiation. So that's the type of thing that I think is advantageous there. And it is a big accelerator, and those proton therapy systems are really expensive, but that's what's going in behind Huntsman. And I'm sure the radiation oncologists are pretty happy about that because it's exciting for them. Okay. All right. So in summary, and this is facetious, but it's also true. In nuclear medicine, we inject a person with radioactive waste, and then we surround them by special crystals that detect the person's energy and start glowing. Okay, that's it. It's absurd. It's kind of mystical, but it also is what we do. And I think it's a miracle. Like this technology we have is just fascinating. Understanding how PET scans work, it's like otherworldly to me. Is almost similar with MRI. I think MRI and PET are both some of the greatest machines that we've invented. Of course, I'm biased, but it's really cool stuff. But when you really think about what we're doing, it's also crazy that it even works. You know, inject someone with radiation, put them around crystals, and suddenly you get images that look like this. Okay, it's really cool. Okay, SPECT versus PET. I already talked about that a little bit. So X-rays, here it is. X-rays are from electrons emitted outside the nucleus. Don't try to remember this. I'm not going to quiz you on this. Gamma rays are electrons from within the nucleus. So there is a difference, but essentially they are the same thing, and the body's effect in terms of cancer risk will be the same. PET. With PET, you image annihilation photon pairs. Okay, and these are kind of also like gamma rays. But a positron is the antiparticle of an electron. What happens is you inject positrons into the person's vein, IV injection. Usually it's going to be FDG, which is fluorodeoxyglucose. And I just think of that as radioactive sugar that's tagged with a positron. And as that goes in the body, the GLUT transporters, GULT, take up the sugar. It'll go preferentially to cells and tissues that are really metabolically active, okay, really sugar hungry. And cancer loves sugar, so it's going to take up more of that sugar than your normal tissues. At least that's our hope. And then when it goes into the tissue, those positrons are going to find electrons. And when they meet, it's like, the worst romance you can think of. As soon as they meet, they're both gone. Okay, they disappear immediately. They are annihilated. And when you annihilate matter, you go back to Einstein, we're talking E equals mc squared. So you have mc squared on one side, you have E on the other side. If you get rid of the matter and the mass, you release energy. Okay, it's all what Einstein said, E equals mc squared. So you annihilate the photon and the electron after they meet, and then you get this photon pair, which is the energy that's given off from that annihilation event. And then we have crystals around the body that are set up to detect the pair of annihilation photons. And then using really smart computer math and all of that reconstruction methods, you get a PET scan. And what it shows you is basically a sugar map of the body, or a metabolic map of the body. And it shows you which tissues are using more sugar than others. And using that, it allows very powerful evaluation of cancer and other things. Okay, but that's the basic idea behind PET is annihilation, and that positron annihilation event gives you gamma photons that we then detect with the PET camera. Okay. What physiology can we image? You have to memorize this entire list. Actually, you don't. It's really big, and this pretty much what I took a year or 16 months learning. But there's a lot of physiology you can image. Just look through here. We're hitting pretty much every organ system. There's not a lot of OB with nuclear medicine, but otherwise, you're getting at a lot of stuff. Every part of the body, different things, renal function, liver, brain. You could do cool CNS stuff and neuro stuff like Parkinson's disease evaluation with DAT scan, a lot of cancer imaging. There's Alzheimer's evaluation with amyloid PET, which is a hot area right now. So we really get at a lot of physiology, and I give a lot of credit to nuclear medicine doctors who have figured this all out. And a lot of this early work kind of happened around the time, shortly after World War II, when we actually started having reactors and started figuring out what we can do that's useful instead of just building atom bombs. That's kind of how nuclear medicine started, was kind of that post-World War II era where we had this renaissance in understanding of nuclear physics. And then they went and applied this to medicine. And a lot of this stuff they figured out is still helpful. Other things on here we hardly do anymore because things like MRI can replace it. Um, here's possible therapeutic agents. This might be my last slide on therapies. Um, so let's run through it quickly. So we talked about iodine, okay? Radium-223, this is also called Xofigo. This is really cool. It got FDA approved, what was it, maybe 4 or 5 years ago for metastatic prostate cancer. And what this is radioactive radium. This has alpha particles. Iodine has beta particles. Alpha particles are even bigger and badder. They cause more tissue damage. And radium is a lot like chloride and calcium, or sorry, it's a lot like calcium, and it goes to bones. So what they figured out is you have this radioactive agent that can bombard cells around it, and it likes to go to bones. So you could use it to treat metastatic prostate cancer. And the initial trials actually showed that you not only help things like reduce pain, but there is also a slight survival advantage if you treat patients with radium. Now, this only pretty much goes and treats bone. It doesn't treat soft tissue metastases like lymph nodes and that type of thing. But it also doesn't have hardly any side effects. The one thing you have to watch out for, because you are radiating the bone and the marrow, is that they don't fall too low with their blood counts and white blood cell counts, that type of thing. But it can work really well. We've treated a lot of patients at the U with this. Trials are ongoing to see if this can now be beneficial for metastatic breast cancer and other cancers. Lutetium-177 dotatate, this is Lutathera. This was recently FDA approved, and you can use this to treat GI neuroendocrine tumors. The dotatate selectively goes to somatostatin receptors, and neuroendocrine tumors have a lot of those. So this is another way where you could do an IV injection. The patients have more side effects in this case, but it still doesn't compare to something like a toxic chemotherapy. And you could get good outcomes from otherwise, poorly treated neuroendocrine tumor. Y90, that's kind of the bread and butter of like hepatocellular carcinoma treatment and stuff that IR does. Y90 procedures, typically the interventional radiologist will go in and selectively canalize the artery or vein of interest, and then they get the Y90 from us and inject and treat those cancers locally. I'm sure you're all familiar with this. It works really well. You may be less familiar that nuclear medicine is working in the background to help make these work too. And you could do things like before you treat, you can do a planning exam where the IR doctor goes in and selects what they think are the arteries to the hepatocellular or the cancers in the liver they want to treat. And then you do a test injection, bring them to nuclear medicine, and you see, did this end up where you think it did? Did a lot of this end up in the lung? Because you can have shunts to the lung, and you don't want Y90 ablating your lung. That would be bad. So we do planning and things like that to help our IR colleagues be able to do this as successfully as possible. And then there's I-131 MIBG, and this has been a frustration among nuclear medicine doctors that people in Canada and Europe have been using this for decades to treat, things like neuroblastoma in kids. The FDA didn't approve it here for a long time, and even now it's still kind of rolling out in the country. But finally, we're getting FDA approval for MIBG because this is a fantastic treatment for appropriately selected kids with neuroblastoma or adults with pheochromocytoma. Again, selective ablation of those. This is basically a norepinephrine analog. And so it goes to cells that like to take up norepinephrine, which is neuroblastoma and things like that. Samarium and strontium we don't use anymore because they're really toxic, but historically they've been used for lymphoma and bone metastases. Bone metastases. We've also had other agents for lymphoma that aren't on here, like Bexar. Okay, so that's a little quick run through on therapies that we do. The newest ones are radium, lutetium, and MIBG. And I think the indications for these are going to be increasing. A lot of places like Stanford, for one, are actually setting up complete nuclear medicine clinics. because they expect the growth in these areas to be very robust over the next decade and several decades, to the point that they think nuclear medicine doctors may actually be doing more therapies than diagnostics in the future. Maybe they're right. I don't know. They might be. And the one thing that everyone is looking forward to is that there might be some PSMA directed therapies, which would allow you to specifically treat soft tissue and bone metastases of prostate cancer. And if that works well, which it looks like it might, that could really take off. And there's a massive population of men with metastatic prostate cancer, obviously. And some of these emerging nuclear medicine therapies could potentially be really impactful and also keep us really busy treating all the potential patients that could potentially benefit from that. Okay, so we're going to do a quick run through of these. These are all scans that you're going to see in your career. Okay, I think pretty much no matter where you end up, even I don't even think you can escape nuclear medicine with psychiatry because we do Alzheimer's and some Parkinson's, dementia, Lewy body, dementia, that type of stuff. So we have a little foothold in a lot of areas. Thyroid, we've already pretty much covered. I'm just going to mention there are different agents that we can use. We have I-131. This one specifically has the beta particle for therapy. 123 does not, but it allows you to image at lower dose. So this might be better for initial imaging. This is therapy. You can image with straight up technetium, or, and we already had the question, what happens if the metastatic thyroid cells don't take up the iodine anymore? Well, in that case, you have a fallback with FDG. Is that slide here? Not yet. Hold that thought. We're going to get into that in more detail. So here's a I-123 scan, looks pretty much identical to the I-131. You can also do full body iodine scans, and this now becomes really helpful. For Graves' disease, not helpful. For cancer search, helpful. Okay, this is a whole body search for cancer. And what we're showing here is this was the pre-therapy I-123 scan that didn't show anything. Then we treat with I-131 at a substantially high dose. And now all of a sudden, because you can also image the 131, you bring them back a day or two after their treatment and image after they've had a whopping high dose. And now you're starting to see sites of metastatic disease. Okay. So this is a good way to screen the body for thyroid cancer. Thyroglobulin, this is a lot of text. I'm not going to read it all. Basically, I want you to know that this is a serum marker, a blood marker for thyroid cancer. And how this works, so the thyroid cells normally secrete thyroglobulin after you treat thyroid cancer. First, typically for cancer, not for Graves' disease, but for cancer, usually the surgeon will go in first and remove the tumor and the thyroid. And then after they've had it removed, you then treat with iodine to kind of clean up everything else, get all the microscopic disease that may have been left behind, and treat any metastases. After you've gotten rid of all that thyroid tissue, the body's thyroglobulin level should be, pretty close to zero. What you could do thereafter is keep checking the thyroglobulin level. And once it starts to tick up, hopefully it never does, but if it starts to tick up, you know that cancer is back somewhere, because only thyroid, pretty much only thyroid makes thyroglobulin. So it's a good serum marker. And what it increases is time to get a full body iodine scan, okay, something like this. Now, if you get your full body iodine scan and you don't see anything, so hypothetical scenario, that's what I'm talking about here. They're treated, thyroglobulin levels are low, and then after 3 years, they start to creep up, and you get your iodine scan and it's negative. You do an ultrasound of the thyroid bed, it's negative. What do you do next? The answer is you get a PET scan. This gets into well-differentiated and poorly differentiated. We're almost at 2, so I'm going to cover this, and then we're going to take a 5-minute break. This is a concept that's important to understand for anyone interested in cancer. So well-differentiated tumor cells behave like the native tissue. In the example of thyroid, well-differentiated thyroid cancer cells take up iodine. With breast cancer, well-differentiated breast cancer has estrogen receptors, okay, because that's what breast tissue does. as it becomes poorly differentiated, it starts to lose those features of the native cell. And when that happens, these cancers get more aggressive, and you ideally would be able to catch cancer and treat it completely before it's poorly differentiated. But poorly differentiated cells tend to be really sugar hungry. Okay, they get more aggressive, they divide faster. And so this is a common principle that as things become poorly differentiated, FDG PET becomes more useful. Um, and here's a case of an FDG PET showing uptake in the thyroid bed in an iodine, non-avid iodine tumor. So on an iodine scan, this didn't show anything. Now PET scan, it's sliding up very clearly. Okay. This principle applies to a lot of things. Prostate cancer, we have imaging agents for well differentiated, and then when it becomes poorly differentiated, you get a PET scan. Neuroendocrine tumor, we have dotatate PET CT for well differentiated. These are the ones that have somatostatin receptors. Then as it becomes poorly differentiated, it loses that, and you can now pick it up with FDG PET. So we kind of have this ability to image the spectrum of disease, whether it's well or poorly differentiated. And this can give useful information to know, what's the uptake on a dotate scan. And if it doesn't show a lot of uptake, you know that this cancer is now transforming to a more aggressive version. And maybe at that point, you change your therapy. Okay. So let's go ahead and take a 5-minute break. It's 1:56, so I'll start at 2:01, and we're going to cover these pretty quickly, probably in the next half hour. I think we'll get through these, and then for the last half hour, I'm going to show some cases. Okay, so see you back in 5 minutes. All right, let's get back into this. Sentinel lymph nodes. All right, this is something that is important to know. You see there's also a quiz question associated with this. So a sentinel lymph node is the first lymph node that lights up in a specific lymph drainage basin, okay? And let's first get the overview of what we're trying to do here. So if you have, let's use an example that you have melanoma. Well, not you, that's not a good thought. I don't want anyone to have melanoma, but let's say, a patient comes in, you see they have melanoma in their upper back, and it's clear that that melanoma needs to get cut out. But what about any lymph node metastases? How are you going to know if they're metastatic? Well, one way to know is if you do a staging exam like a CT and you see really big axillary lymph nodes, it's pretty clear that those are going to be metastatic, or you see big lymph nodes in the back. There are nodes in unexpected locations. Those are called in-transit nodes, and they can pop up when you have cancer, or maybe that upper back melanoma drains to the neck in the cervical nodes. So if you get a CT, you could do neck, chest, abdomen, pelvis, and you see some big lymph nodes in the neck. Those are probably going to be metastatic. You could do a biopsy if you wanted to. You could go in and remove them with surgery. But what if you do those initial staging scans and all of the lymph nodes look normal? Does that mean that there is no cancer in those nodes? And unfortunately, that does not mean that there is no cancer. Okay, no imaging study can definitively exclude cancer in a lymph node, because a lot of times that cancer might still be microscopic, and we only are able to see change when it becomes more advanced. You have to have a lot of cancer grow in a lymph node to make it big, but it can harbor microscopic cancer and still look normal on an imaging scan. So you have the option, which is what used to happen, that you go in and you just cut out all the lymph nodes you can find, take out as many as possible. For breast cancer, that would happen a lot of times. You just go in, take out all the axillary lymph nodes. If you palpate supraclavicular lymph nodes, take those out and then go, and the pathologist will tell you whether they had cancer or not. In that case, you could have, let's go back to the melanoma case. Let's say you go in and you take out 10 lymph nodes and every single one of those is negative. Well, you've benefited the patient in that you evaluated for cancer, but you've now removed 10 lymph nodes, and lymph nodes do something for you, right? And one thing they do is drain fluid. And you may now have caused some long-term, never get better edema, lymphedema, other issues for these patients that are not negligible. Some patients who have had a complete nodal dissection have a lot of symptoms from it. It can be something that affects them every day of their life. So that caused surgeons to pause and say, maybe we shouldn't take out every lymph node. Maybe we need a better way to identify whether the nodes have disease at all or not. And that is what led to this sentinel lymph node study. And what this allows us to do is map the sentinel lymph node basin anatomy. And what we are looking for are, if we inject this melanoma in the back, which lymph nodes are going to light up, okay? Because that tells you what the first node is. So you watch on the imaging literally for the first nodes to light up, and you can do sequential imaging to see. And when you identify the first nodes that light up, the surgeons go in, they have some, radiation probes they can use to find which lymph nodes have a lot of this radiation in them as well. And you remove only those sentinel nodes and you leave the non-sentinel nodes alone. So in the case of breast cancer, you may now only remove 2 or 3 sentinel nodes and leave alone the other 7 nodes. And in that case, you've benefited the patient, because if those sentinel nodes do not have cancer, and they are the first lymph nodes that would drain the cancer, you can presume safely, we've seen from research, that all of the other nodes also don't have cancer, and now you've spared the patient from having complications from a complete nodal dissection. Okay, so that's one big benefit. The other benefit is that you can sometimes identify unexpected drainage that you wouldn't have otherwise known. And the reason I chose the upper back melanoma is because that's known to be a really problematic area because the drainage is unpredictable. Okay, and you can see here you have these two main drainage networks. This is SAPI's line here, I guess. I'm not quizzing you on that either. But it can go up or down. So what if you have something on your back here? Okay, sometimes it might, or you have something on your, abdomen here. It may go down to your inguinal chain. It may go up to your axillary chain. It could go into the internal mammary chain. So the sentinel lymph node also shows you which way is the nodal drainage and where, by extension, does the surgeon need to go evaluate. Here's the nodal drainage pattern for breast. You have axillary, you have some supraclavicular, you have internal mammary. Those are by far the most common. And you go in, you inject technetium, you inject some blue dye. You can, not everyone does the blue dye, and then you watch it travel up to the node. This is the first draining node, so that's your sentinel lymph node. The surgeon will go in and remove this node and maybe a couple others around it, but you leave all of these behind. And you let these tell you what's going on. If these are positive, then the surgeon may go back later and take a lot more. But in that case, you are actually much more likely to benefit the patient than if you just take them off at the start. Okay. Really, we do this for breast cancer and melanoma. Most other cancers, we don't do it for. Okay. And this is just showing the intraoperative probe the surgeon can use. And if you've been in the OR, you'll never forget how these sound, but they make really distinct sounds when you get closer to the node. The thing starts beeping at you. It sounds like it screams at you, basically. It's like you're here, no, 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 and then yes. And it goes really high and loud, and then you know that your node's down there, and they'll go in and take it out. All right. So this study does not confirm whether a lymph node has cancer. That's a very common misconception. Okay, sentinel lymph node study does not show you if a node has cancer. It only shows you what the draining node is. All right, and here's lymphedema, okay? And it can get a lot worse than this, but even this much would be bothersome. Okay. Here's some actual images. So here is a back base of neck melanoma, and this was unexpected, drained. Well, maybe not unexpected because it's midline, but still you wouldn't be able to predict necessarily. It drained to both axilla. So in this case, you'd have to do a sentinel and the lymph node on each side. Here's a trunk or abdomen. I can't quite tell. It's probably on the front, yeah, because it's going to the inguinal chain. So this was a melanoma that drained both to the inguinal region and an axillary lymph node. So again, you'd want to go excise both of those. Without having this study, you wouldn't know if you had to go here or here. VQ scan. I think you're familiar with the VQ scan a little bit. It's most commonly for acute pulmonary embolism. You can also do it to evaluate for pulmonary hypertension, chronic pulmonary embolism, which means you've had PEs and they didn't completely resolve. And that can cause pulmonary hypertension. You can do this scan for preoperative planning if someone's having, maybe like a single lung transplant, or you have to remove a cancer from a lung and you need to know how much ventilation is that lung providing the body. You can tell that from a VQ scan. You get the physiology of the lungs with this. And you can also use it to evaluate for a right to left shunt. VQ, V is a ventilation, Q is a perfusion. So you are looking at either one individually or combined to see, is there a mismatch? Are there areas that are perfused but not ventilated? Or more useful for PE would be ventilated and not perfused. A lot of physiology you can get out with the VQ scan. So not everyone gets a VQ scan, nor should everyone with suspected PE get one. CT pulmonary angiogram is your test of choice for PE. Okay, I would always recommend getting the CT first, and you end up getting a VQ scan if they cannot have a CT. So maybe they have an iodinated contrast allergy, maybe their CT angiogram was non-diagnostic. That can happen a lot of times if the contrast timing is off, because for a CTPE study, the technologist has to very accurately time the contrast administration. And if they image too early or too late, you won't have the contrast in the pulmonary artery tree like you need. And in that case, you can't necessarily exclude a PE. You can't repeat the study because they can't have that much iodine in a row. So then they're getting a VQ scan. Recently postpartum pregnant. Now, pregnancy is not a contraindication to having a CT. But there are some dose reduction things you can do with a VQ scan. You actually only get the perfusion scan and see what that shows. And if the perfusion is normal, then there's no PE and you're done. Some other things, okay, a few indications. The main one to know is PE. And you also need to remember the Wells criteria. You know that better than I do at this point, but the overall determination of whether a VQ scan, of how you interpreted it, takes both imaging findings and clinical suspicion into consideration, okay? So for a VQ scan, we always need a chest x-ray or a CT. So when you're in an internship, when you're interns, you can make your radiologists and nuclear medicine doctors really happy if anytime you order a VQ scan, you check to see, do they have some sort of chest imaging within the last 24 to 48 hours. You have to have the chest imaging to be able to interpret a VQ scan. So if you haven't ordered that, you're going to be getting paged in a phone call saying, hey, we need a chest x-ray. Okay, so within 24 to 48 hours, depending on the institution, you need some chest imaging. Then we get the perfusion. We see any perfusion abnormalities. How big are they? And then usually you do the ventilation first. You look for ventilation defects, then you get the perfusion. And the key is that for a diagnosis of PE, you are looking for moderate to large mismatches between ventilation and perfusion, meaning the lung can ventilate normally, but it has lost its blood supply because there's a clot in the pulmonary artery. Now, if you've lost both ventilation and perfusion, you may remember from physiology that as the lung stops being able to ventilate, whether due to atelectasis or consolidation from pneumonia or whatever's going on, where you have a lung issue, the body naturally reduces blood flow to that area of the lung, okay? Called hypoxic vasoconstriction. So areas of hypoxic lung, the body automatically shunts blood away from that area. And when that happens, that gives you a matched defect. With a PE, you don't have any ventilation problem. It's just purely on the perfusion side. So you expect normal ventilation, abnormal perfusion in a segment of the lung. You do have to know these segments to read a VQ scan, and how we read it is determined on whether the mismatch is large, moderate, or small. Okay. Here's an example of a ventilation scan. This is with xenon, where you breathe in the xenon, you see it come into the lung, and then you see it breathe out of the lung. It's a very quick in and out. And what we're doing is looking to see, does this look uniform? Are there any chunks missing? And then we get a perfusion scan, and you see, are the lungs perfused throughout? And this is a good example of a normal. Here's an example of an abnormal. Look on this one, how the perfusion, you have this web-shaped missing area of lung. This part of the lung is not getting blood flow. And then you look over here and you say that part of the lung is getting ventilated, and then we say PE, okay? The criteria is very complicated. I don't like VQ scans a whole lot for this reason, because it's just not that easy of an exam to interpret. There's a lot going on. And the key is that you end up getting a likelihood or probability of a PE being present. Okay, VQ scans give you probabilities. So normal, very low, low, intermediate, or high. You combine that with the clinical probability of your suspicion, and then you have these algorithms that have been established through research on what to do. Right to left shunt, just so you know, it can do this. You inject, and then you basically look and see, do you have brain uptake? Because if you inject in a vein, those particles should get stopped in the pulmonary system. Okay, the lung kind of acts like a filter of the blood. So you inject these MAA particles, they're very small particles, and they are large enough that they actually embolize in the lungs. So when we do a VQ perfusion scan, we're actually causing microembolisms, but we are only embolizing a very small amount of the available capillaries that is really not significant physiologically. But sometimes we do inject a lower dose if we're worried that, hey, this patient's not doing well and we don't want to block even more of the blood supply to the lung. But the key is for this, they're supposed to not be able to get past the lung. They're supposed to get stuck in the pulmonary vasculature. So if you inject and all of a sudden the brain lights up, you know there's a right to left shunt. Okay, it's an easy exam. You can also quantitate and actually get percentages. In this case, the left lung is providing 45% of the ventilation, the right lung 54%, and then the surgeon can decide. In this case, if they have a choice that they're going to transplant one lung, they would choose the left, the one with the lower amount of lung function. Okay, PET scan. I think you're fairly familiar with this. I'm pretty much going to skip, other than just know it's not all about F18, FDG. When I was a medical student, it was, you are now a medical student, and it is no longer the case, okay? We have a lot of other options and more coming online. Ones that we clinically use here at the U, we use a lot of dotatate PET. I don't even have that on here, but yeah, I do. We also do fluciclovine for prostate cancer, and we do Amivid for Alzheimer's. PSMA is coming, so watch that when the big trial is announced, which will be soon. This will probably be a New England Journal of Medicine article. That's going to change a lot of what we do, I think. And here's the thing with the annihilation. It goes in, it annihilates, you get this pair of photons after the annihilation, and then you use your crystal ring to say, hey, that happened along this. And these detectors are actually so sensitive that even though these photons are coming out at the speed of light, they're able to say it hit here earlier than here, and therefore by deduction is located here. Okay, a little bit closer to this than this because it knows that it hit nanoseconds earlier on this one compared to this one. That's kind of impressive that you can detect differences in the speed of light in, like a, 3-4 foot ring. Here are different examples of PET. FDG is what we most commonly use. Here's what dotatate looks like. Notice the pattern is different. You have brain uptake here, you don't here because this is imaging where you have somatostatin receptors. And then we have fluciclovine over here that has a really hot pancreas. Just the thing to know is each has their own physiologic pattern. As a radiologist, you have to know what those patterns are. You have to know that, hey, this uptake in the pituitary is normal. And then you have to go from there, okay? But that requires some knowledge of physiology. Bone scan. I will admit it, when I was an intern, I rotated at the Naval Medical Center in San Diego, and my attending told me to get a bone scan, and I didn't know what he was talking about, which is funny that I'm now a nuclear medicine attending, but I truly didn't know. I was like, is that an x-ray? What is it? So you're not going to fall in that trap. You probably already know, but I'll make you smarter than I was. So a bone scan is a nuclear medicine study. That's what I didn't know. And then he assigned me to read about it, and I became informed. Bone scans can assess for bone metastases, osteomyelitis, infection, other niche things like reflex synthetic dystrophy, metabolic bone diseases like hyperparathyroidism, and fracture evaluation. Do they have a stress fracture? Is there non-accidental trauma? An x-ray is normal, but you're suspicious. You can get a bone scan to see. There's a lot of uses. One thing I want you to know, osteomyelitis requires a 3-phase bone scan. Okay, whenever we're talking about infection, also things like stress fracture, but especially infection, you need to get a 3-phase bone scan, okay? If you just order a bone scan, it's just going to be a single-phase whole body scan. Key points, bone scan is more sensitive than a CT scan for bone metastases. So we see this frequently where patients have a cancer, say they have prostate cancer or a breast cancer. You get the staging CT scan and the bones look fine. Then you get the bone scan and you realize the bones are not fine because a bone scan will show you the metastasis earlier than CT. Um, that's why the NCCN guidelines for cancer staging typically for certain diseases like prostate and breast cancer that go to the bone a lot, they recommend getting both a CT and a bone scan together. It does not show all types of bone metastases. I do think this is not beyond what you need to know because it is the clinicians and the interns who are ordering these scans. If you have a cancer that tends to have blastic metastases, such as prostate and breast, even though breast can be mixed, it's often blastic, you want a bone scan. If you have a cancer that has lytic metastases, like multiple myeloma, renal cell carcinoma, some of these very vascular cancers, you want a PET scan with FDG. These are kind of complementary to each other. Between both of these, you will see pretty much all of the cancers because this will cover the blastic, this will cover the lytic. There is some crossover, it's not mutually exclusive, but this is a good rule of thumb. This is why we often don't get FDG PET scans on patients with prostate cancer because the FDG PET is good for lytic metastases, but it may not show you uptake in the prostate cancer blastic metastases. Okay. 3-phase bone scan is for infection imaging. A standard bone scan is a single delayed image. Okay, I think if you remember what's on this page, you're on a reasonably good footing. This is what a bone scan looks like. This is a very high quality bone scan. They often don't look quite that good. And notice in this case, here's a CT. And this is largely lytic and you see mild uptake, but there is some uptake here in the pelvis. Here's another example, bone scan of the pelvis, CT looks really bad. In this case, notice how lytic this is, and you don't see a whole lot of uptake. So you can imagine if this were very small, this is obvious because it's big. If it was very small, you could easily miss a very lytic metastasis. And you see the activity you actually are able to pick up is where there's this bone building on the periphery, but in the center, you don't see anything. If you got a PET scan on this patient, this whole center would just light up like crazy because this is all tumor. Okay, it would be very sugar hungry. Cardiac imaging, there are several things we can do. One, you can evaluate to see if there's coronary artery disease with blood flow. If you end up as an emergency room doctor, you're going to deal with this a lot. Patient comes in with chest pain, is it cardiac or not? There are several options you can get. You could get your cardiac enzymes and you could do a stress echo or you could get a cardiac CT or MRI, but a lot of times the easiest and quickest way to get this evaluated, especially on weekends, stuff like that, is to do a myocardial perfusion scan where we use sestamibi and look to see if there's abnormal perfusion in a coronary distribution. We can also assess for viability, and when that one matters if you have a patient with a myocardial infarction and some of their inferior wall is not contracting anymore. You can guess that that's dead, but it may not be dead. It may just be stunned and hibernating. After an MI, the cells are damaged, but they may not be damaged to death. Okay, they may just be damaged enough that they're going to kind of hang back, say, hey, I'm just going to kind of relax for a while. The rest of you guys can pump the blood, but I'm just going to hang out until I recover. And that is actually viable heart. And why that matters is if you go in and revascularize that area, all of a sudden you're going to see that start to pump again and the patient's EF is going to increase and they're going to do better. So we can tell with nukes, you can also tell on an MRI about viability. Okay, I like this one. Your friend is only mostly dead. That's pretty much what we're looking at. It's like, yeah, this heart's not great, but mostly dead is slightly alive, and that is absolutely the case in a lot of cases where your EF can be horrible after an MI, but then you revascularize and all of a sudden your EF is normal. But you don't revascularize everyone because it's a wasted procedure and extra surgery and cost and all of that. If you revascularize what's dead, it's never coming back, right? So what you need to know is this viable or not? Thallium and FDG PET can show you that. So there's this, ischemia, hibernating, stunned, or dead. Just know that any of those are possible. This is beyond what you need to know. But you see for this stunned, you revascularize, okay? There's a lot of ways we can do this. This is beyond what you need to know, other than it gets complicated. You can also assess for cardiac amyloidosis with nukes. And this is kind of what a scan looks like. The left ventricle is a lot bigger. It takes up more. Sestimib is a marker of mitochondrial density. Again, getting at the physiology, you see more mitochondria in the left ventricle compared to the right. And we're really looking to see, is this uniformly distributed in all the territories of the coronary circulation, and we have different views that we look at. And then you image like this when someone's resting, and then you stress them in some way, and then you image again. And if you see that their stress looks really bad, but their rest is okay, that is the imaging equivalent of ischemia. And those patients go to the cath lab. Okay, so like this, rest, you got perfusion here, stress, perfusion's lost, LAD's not happy, they're going to get a cath. Okay. Renal scan, a lot of valuable stuff here. Peds, if you end up as a pediatrician, you're going to do a lot with this. Obviously, nephrology and internal medicine are going to have a lot with this. These exams are still done commonly. They're very valuable in the type of information they can give you. So you can look for a lot of stuff. Function, evaluate renal failure. With pediatrics, you can evaluate for reflux. You can confirm if there's renal vascular hypertension, and transplant, you can look at what the blood supply is, how the transplant kidney is functioning, is it obstructed, all of this stuff. So this is a MAG3. I would know that MAG3, not for the quiz, but for your actual life. MAG3, that's going to be the majority of the renal scans you would order. And a MAG3 scan is great because it shows you the blood flow. So you inject, here's the aorta. Hey, within seconds, you're seeing the kidneys light up, which is what happy kidneys do because they're very vascular. Okay, you have good blood supply to both of these kidneys. Then you watch to see the cortical transit. It ends up in the cortex, so it's not totally dead. And then you want to see, is it actually moving out of the cortex into the bladder? And so you keep imaging over time, and this tells you function. Okay, this is anatomy a little bit. This is function, okay? Blood flow in the cortex, is it now moving through the cortex to get excreted? Yes, it is. Are they doing it symmetrically? Yes, they are. Is there obstruction? No, there's not. Okay. And you can generate these curves as you image over time. So you see, after you inject the radiation, you basically watch to see how it moves through the urinary system. So it comes in to the cortex, it builds up, builds up, builds up, and then it starts to excrete. And it excretes out, excretes out, excretes out. And we have normals, so we know what a normal time is. If this excretion is really delayed, we know there's some amount of obstruction. We can quantify if it's a severe obstruction or a mild obstruction. That's really helpful for urologists to know, do we need a stent or not? For transplant, you can evaluate the how robust is the blood supply, because that's a big question for them. If you see a nice sharp uptick, you know that the blood is good, it's getting there quickly. If the increase is something like this, hey, that blood supply is not great, or the renal function isn't great. We have ways to figure that out. Okay, obstruction is going to look like this, happy kidney like this. And this is from an actual study. So we actually get these curves, this is going to be the right. So the right kidney is obstructed, the left washes out. And you see that as you look through time, that this activity in the right kidney isn't clearing. Now, some of you may be saying, hey, he's saying right kidney, this is actually left kidney. I think this is in your chapter that you have to be aware on a renal scan, we are imaging from behind. So if you're looking at a person from behind, this is the right and this is the left, and it's kind of an exception to our usual radiology rules, okay? For peds, they can do DMSA imaging, which gives you an image of the renal cortex, and basically this tells you, is there pyelonephritis or is there renal scarring, okay? And those images look like this. And that can come into play, like say this is an ultrasound, you have something here in the mid portion of the kidney. Is that a mass? Is that normal kidney? There's something called a column of Bertin. Bertin. For those going into peds or with particular interest, you can try to remember that. Column of Bertin is normal tissue that can look like a mass in the middle of the kidney. And the way to figure that out is with a scan here. So you see that this has uptake in the cortex. This is normal renal cortex, not a mass, okay? You can look at the function of each kidney. In this case, the function is very close. They should be close like that. If the right kidney is doing 80% of the work and the left kidney is only doing 20, this type of scan would tell you that. And you can imagine how useful that is. Like for pediatric reflux, for example, this will tell you how bad the reflux is in terms of how much damage is it causing to the kidney. So if you watch over time and you see that, there's reflux in the left kidney and, hey, that renal function is dropping off quickly, the right kidney is doing a whole lot more of the work, that might be like enough to go in and do a, ureteral reimplantation, some large measure that you wouldn't want to do if things aren't that bad. So this type of study can give you that type of information. All right. And this is a transplant evaluation. Here are the kidneys down in the lower quadrant. You only have one of them, and you can see the blood flow and then the function. Okay. Brain imaging. So we can look for dementia. We've been doing that for quite some time with FDG. Now we're starting to get amyloid imaging, which can confirm amyloid neuritic plaques. And when I was a medical student back in the dark ages of the late 2000 and 2007 to 11, we didn't have this scan. So I was taught as a medical student that the only way you can confirm a diagnosis of Alzheimer's is on autopsy. And I found that a little disheartening because it's like, well, you probably want to know about that before they were dead, right? But you could guess at it, but the only way to confirm it was on a pathology evaluation of the brain at autopsy. Well, nuclear medicine doctors stepped in and figured out a way to image the plaque. Because if you don't have amyloid plaque, you don't have Alzheimer's. Now, the converse is not true. If you have Alzheimer's plaque, or amyloid plaque, sorry, if you have amyloid, that does not mean you have Alzheimer's. But if you do not have amyloid, you don't have Alzheimer's. And that's really sometimes where it's more valuable for the cognitive neurologist figuring this out, is that you can exclude the possibility of Alzheimer's. With FDG, it's approved for evaluation of Alzheimer's versus frontotemporal dementia, and it works reasonably well. Sometimes it's very clear. A lot of times it's not as clear, and so you're still left scratching your head a little bit. Brain tumor imaging, honestly, we don't do this that much. There's still some research interest, and maybe occasionally we might do it, but MRI is kind of taken over. Although I would say MRI is not perfect for this either. But it's an important question in the brain. If you see enhancement or something around the periphery of a resection cavity, is the cancer back? Is there residual cancer, or is that just scarring from radiation or surgery or whatever it might be? And so MRI, you can do fancy MRI perfusions and get these blood perfusion maps and stuff to help with that, and diffusion maps and whatever. You can also try with PET, but one hard thing with PET in the brain, at least with FDG PET, is the brain uses a ton of sugar. And so you may not be able to see the cancer over the brain because they're both chewing through a lot of sugar, so you don't have great signal. Dopamine transporter imaging is a super cool exam. I think I have an image in here, and it evaluates the dopamine transporter density in the basal ganglia. This is newer in terms of nuclear medicine scans, and what I love so much about this one is it's kind of a binary yes or no. Okay, there's not that many studies in radiology where it's just like a definite yes or a definite no, but this is one of them almost all the time. You can do seizure imaging to look for seizure foci, and you can do a brain death study, which we'll talk about. So this is an example of where FDG PET did work, and even though the brain's taking up a lot of sugar, it's not doing as much as the metastases, and you can see these are viable tumors. Okay, we're getting a little bit at physiology. If it's eating glucose, it's alive. Okay, viable tumor. Here's what an amyloid scan can look like. This is the Pittsburgh compound. They're the kind of first people to do this. We now have other ways which are like this, and you can get maps like this. And if you have uptakes, this would be a positive scan. This patient has amyloid plaque. Okay, this is what a negative scan can look like. This patient does not have amyloid plaque. This patient does not have Alzheimer's disease, even if there's clinical suspicion of that. So then that allows the neurologist to look for other causes of dementia. Brain death. I hope you never have to order this too frequently, but occasionally it certainly comes in. And with the brain death scan, it's an important determination on everybody's part whether you're going to withdraw care. So what we're really looking for is there cerebral perfusion or not? So in this case, you have an angiographic phase. You see the carotids light up. You see that it starts to diffuse into the brain. So in this case, this patient has perfusion to the brain. This is a different case where you're looking later, and you may notice that this is a bit different than this, okay? In this case, you see some uptake in the dural venous sinuses, which can be normal. You see a hot nose, which is a bad sign because that means the blood is getting stuck here, so it's going there. Okay, can't get into the brain, so hey, we're going to go forward into the nasal tissues. That's what brain death can look like. This is what brain death can look like. I shouldn't say brain death. This is what absent cerebral flow can look like. And I'll tell you why in a minute. Absence of cerebral blood flow. Okay, what causes that absence of blood flow is increased intracranial pressure. So say this is a motorcycle trauma patient and they hit their head really hard and they have a lot of intracranial bleeding and injury and swelling, and maybe it develops over, hours to days, and they progressively go comatose and then lose their reflexes, and there's clinical suspicion of brain death. You can confirm that. And as the intracranial pressure builds up so much, not CSF, but intracranial pressure, it eventually gets to the point that the blood pressure in the arteries isn't enough to get the blood in there, and it just stops. And at that point, the brain will essentially all infarct. Okay, so brain death study confirms absence of cerebral flow or presence of cerebral flow. It does not confirm brain death. Okay, that has to be a clinical determination based on, respirations. You've gone through neurology, probably most of you at this point. Make sure you know what they do, with reflexes and all of that. But in the clinical suspicion, if further confirmation is necessary, you can get the nuclear medicine scan and it can support the clinical diagnosis of brain death. This is an image of a DAT scan, and you look to see uptake in the dopamine transporters in the basal ganglia. And you want to see the caudate and the putamen. In this case, the putamen, they look like little commas. It's really almost completely absent on the left. On the right, maybe there's a hint, but this is abnormal. This patient has Parkinson's disease or a Parkinsonian syndrome, and that's how it is. It's a great scan. Okay. And CSF shunt patency, I mentioned this. You can inject the shunt and then watch to see if it goes down. And if you see spillage in the abdomen, you know that entire length is patent. And GI, we're going to go real quick through this because I want to get through cases. So you can do a few things. Evaluate for acute cholecystitis. You can look for bile leak in a patient who has had a cholecystectomy. You can look for biliary atresia in a neonate. This is what a normal scan looks like. You expect this to be taken up in the liver, excreted into the gallbladder, and then go out into the intestine like normal bile does. This patient does not have cholecystitis. This patient does. Okay, liver uptake. Where's the gallbladder? It's not there, it's not there, it's not there. I see the bile ducts and I see it getting into the bowel, but no gallbladder. That's an inflamed gallbladder. That's what happens. In an inflamed gallbladder, the cystic duct gets blocked. And that's what we're seeing is, hey, the cystic duct is blocked. Therefore, there might be a stone or something in there, but there's acute cholecystitis. Neonates with biliary atresia, This is a very important distinction to make because neonatal hepatitis is treatable without surgery. Biliary atresia is not treatable and it needs early surgery. So there's a double need to find this out early. Okay, it has to have surgery, not treatable without surgery, and the surgery only works if you do it early enough. So we can do this and again see, are there bile ducts present or not? And if they're not there, biliary atresia. So you're looking for transit into the bowel. And this is what biliary atresia looks like. You can image. At 3 hours, there's still nothing. You would even then bring them back, 1-2 days later. And if there's no bowel uptake, that never went through a bile system, biliary atresia, they need surgery. Okay, GI bleeding scan, you're going to encounter this. Patient comes in with hematochezia, something like that. You image this, you take red blood cells and make them radioactive and then re-inject in the patient. And you see the arterial system with the iliacs here. You see this start to develop here and you see it start to change over time. That's a GI bleed, that's an active bleed. That's where the IR doctors need to go and embolize. Gastric emptying scan, I mentioned at the beginning that you can eat radiation. Well, this is one example of when you would do that. If they're wanting to see how bad gastroparesis is, or if a patient has gastroparesis, that types of things, partial gastric outlet obstruction, you have them eat this delicious meal of eggs, toast, jam, and water, and then you watch it move through, and we know the normal rates at each time point of how much emptying you should see from the stomach, and then you can compare it to normal and see if this is abnormal, okay? And you get a curve like this, and you get numbers like this. So this is a quantitative way to measure gastric emptying. Okay, here it is in the stomach, here it is out of the stomach and in the bowel. Okay. And you can also do a tagged white blood cell scan to evaluate for sources of infection. It sounds great. In reality, it's kind of a messy exam. It doesn't always work great, but in the right setting, it can be valuable. A lot of times you might just do an FDG PET instead for like fever of unknown origin, but this is a general nuclear medicine option. Meckel's scan, you can specifically look for Meckel's diverticulum with gastric mucosa, and these are the ones that cause problems. It is possible to have a Meckel's diverticulum without this gastric mucosa, and those tend not to cause problems. So this tells the physiology of what's going on in there. You can do H. pylori testing with carbon. Okay. 15 minutes. Let's get through it. All right. What scan is this? What's the abnormality? I think you're all going to get this. Oh, actually, maybe, yeah, we'll go through a few of these. At 2:50, we'll do the questions, like your quiz questions, if you haven't already done them. Okay, so just in the interest of time, this is a thyroid scan. This is a cold nodule that's concerning for possible cancer. Okay. Here's a different case. We have a chest x-ray. Depending on the quality of your monitor, this may look normal or it may look less normal, but you have little tiny nodules through here. And this is an iodine scan, and holy crap, I thought the thyroid was the only tissue that's supposed to take it up. So what's going on in the lungs? Okay, see all these little tiny dots? These are miliary metastases of thyroid cancer. And this is how it looks on an iodine scan. And this could be unsuspected and seen on a whole body iodine scan. Okay, but this is diffuse miliary metastases that is typical for thyroid cancer at a more advanced stage. What is this? This is a sentinel lymph node scan. In this case, they injected what's likely a melanoma up here, and you see uptake in the cervical chains and supraclavicular region. The sentinel node would be this one, and maybe the first couple that the surgeon would want. Okay. And on these sentinel node scans, you can do a SPECT CT. That's one reason I put this in, is this shows what a SPECT CT looks like. You have the uptake from nuclear medicine merged onto a CT image. In this case, you can use it to show the surgeons exactly where these are. This is deep to the sternocleidomastoid. This one is a 2A node, and so on. Another sentinel lymph node in the back going to the axilla, and in this case you have probably an in-transit node, so those are unexpected nodes that pop up along the drainage chain. VQ scan, notice the perfusion defect here with relatively normal ventilation. Okay, and there's another one down here. So PEs. This is a bone scan. This is hyperostosis frontalis, which is a common, benign, known physiologic entity, and it shows increased uptake here. So you have to know what's normal, what's a normal variation. In this case, this is a normal variant. I'm just going through some example cases so you can see. This is a before and after, so you can use these to follow. So this is an osteosarcoma that was since resected, and now you can use this to see, are there any other areas of disease? This is the injection from your IV. Renal scan, transplant renal scan. In this case, you have a urine leak. Okay, this is a urinoma. The ureter, the neo-ureter, the connection, something's not working right because you have a urine leak here, and we can tell that definitively because the radiation is getting into the kidney, and then as it is excreted, it's ending up here, not in the bladder. Brain death. HIDA scan with cholecystitis. In this case, you see what's called the rim sign, where you see increased activity where the gallbladder is, but that's just because there's inflammation in the liver by it. And on this CT, you see that the wall is thickened and the gallbladder is distended, which is what you look for cholecystitis, acute cholecystitis. Here's a GI bleed again that's positive. Okay. Quiz question 1. Radioactive iodine can be used to treat Graves' disease, pancreatic neuroendocrine tumor, metastatic prostate cancer, lymphoma. All right, I may have gone too easy on you, I don't know, but if you got this right, maybe you learned, maybe you already knew it. Give you 10 more seconds. What do we use radioactive iodine to treat? Quiz question 2. If anybody needs more time, just type in and I can go back, but sentinel lymph nodes. A, the lymph nodes harboring metastatic disease. B, the first lymph nodes draining a cancer. C, always in the expected lymph node drainage basin of a cancer. D, best identified using FDG PET-CT. All right, 10 more seconds. All right, a VQ scan, typically read independent of a chest radiograph or chest CT. B gives a probability of pulmonary embolism being present. C is typically preferred over a CT angiogram for PE evaluation. D confirms pulmonary embolism when matched defects are present. Okay, let's give 10 more minutes. 10 more seconds. All right. Question 4. A brain death scan is typically performed with FDG PET-CT. Okay, so I didn't specifically cover that. It's performed with, not with that. Okay, it's performed with HMPAO or ECD, but it's a technetium scan. It's not a PET scan. Okay, so I'll tell you that because I didn't specifically talk about that like I thought I would. B is always necessary to confirm brain death prior to organ harvesting or end of care. C shows the absence of cerebral perfusion supports a clinical diagnosis of brain death. So a brain death scan that shows absence of cerebral perfusion supports a clinical diagnosis of brain death. D is better performed with MRI than nuclear medicine. All right, I'll give you 10 seconds on that one. All right, question 5. Bone scans are A, better for lytic lesions and FDG PET CT scans better for blastic lesions. B, better performed as a single phase for evaluation of osteomyelitis. C, obtained by performing radiographs of the entire skeleton. D, more sensitive than CT for bone metastases. All right, go ahead and complete that. And then my understanding was that you're emailing these in, and I'm supposed to confirm that you've all had enough time to do that before I move on and give you the answers. So I'll give you just another minute. If you need me to go back to any question, please let me know. If you need more time, just type in a comment more time. Otherwise, I'll give 30 more seconds and then I'll assume that you've all sent it in. Okay, I think we're good. Oh yeah, the bonus. Don't email this response in, but I wanted to see if you paid attention. A kitty corn is an awesome creature that is real. A kitty with a horn, best with rainbow fur or all of the above. Enough time? Just kidding. Okay. All right. So question A, I did bold this. It's not as easy on my screen to see, but it's Graves' disease. I bet you all got that. Radioactive iodine, Graves' disease. We kind of nailed that one. Question 2, sentinel lymph nodes. The first lymph nodes draining to cancer. Before this lecture, I wonder how many of you would have said this, because a lot of people think this way, but that's not what it is. It's just simply the first nodes that drain a cancer. You don't know if they're harboring disease until the surgeon takes it out or you do some sort of biopsy. VQ scan gives you a probability of pulmonary embolism being present. Remember to always get your chest radiograph or chest CT because it's necessary to read these. Remember to always start with the CT if you can, and know that we are looking for mismatched defects on a VQ scan. A brain death scan is not performed with FDG, I told you that. Is not always necessary. Okay, you don't have to get a brain death scan for everybody. If you have sufficient clinical information, then you don't need this. But if there's any doubt, or for whatever reason, the family or anybody, they just have to know everything that is possibly available to answer that question has been done, you can get this. Sometimes there are tricky situations where it's a bit unclear, and knowing whether or not the brain is being perfused can be really helpful. So it's that shows absence of cerebral perfusion supports a clinical diagnosis of brain death. As of now, MRI does not do as well as we do in nuclear medicine. Okay, 5 bone scans. So this could be tricky, but lytic is FDG. Okay, FDG PET scans are better for lytic. Bone scans are better for blastic. For osteomyelitis, you need the triple phase. It's not radiographs, although correlating with radiographs can be helpful, but it's not like a VQ scan where you have to have them for everything. And sometimes we request them afterwards if we think it'll help. A bone scan is more sensitive than CT for bone metastases. That's your answer. I think I emphasized that quite a bit. I hope you got that.